You're listening to Your Magical Midlife. This podcast is for women who are seekers, dreamers, and unconventional thinkers. If you're a Gen X woman who's always walked your own path, but now feel like you've lost your way, listen up. I'm Kate Higgins, your host. I'm a licensed clinical social worker and coach, and I'm here to guide you back to yourself and to help you reconnect with your joy, your passion, and your purpose. Midlife knocked me sideways. I was not prepared for all the challenges that piled up one by one. Everything in my life felt like it was imploding, including my health and my sense of self. By the time I hit 50, I was completely lost. But here's the good part. I'm finding my way, and so can you. I'll be dropping episodes every Thursday on everything from ambivalent aging, to body changes, to relationship shifts, to career challenges, financial fears, crazy family dynamics, and spiritual awakenings. Some weeks I'll be musing, some weeks I'll be ranting, and sometimes I'll have amazing guests who will share their expertise with you. Midlife brings a lot of change and a lot of challenges, but there's also so much magic to be uncovered. Let's dive in. Dr. Cathleen Brown is the medical director of Winona, a telehealth medicine company that offers accessible HRT for women all over the United States. She's a board-certified OBGYN and native of Philadelphia. After completing her residency training in Tripler Army Medical Center in Hawaii, she served on Army bases across the country, caring for female soldiers and female dependents of active duty soldiers. Today we do a deep dive into HRT and finding good medical care in peri and post-menopause. Hi, Dr. Brown, how are you?
I'm good. How are you?
Good. What I really wanted to focus our conversation on is navigating the landscape of hormone replacement. Because even as I have gone through it myself, I have found it to be very confusing.
Yes.
And a lot of misinformation or vague information.
And a lot of roadblocks that a lot of women are meeting actually too. I mean, just trying to get care, just having someone listen and offer you care is kind of hard depending on where you live too.
Absolutely. And doctors have approximately 15 minutes to talk to you.
Exactly.
By the way that I'm a provider as well. I'm a therapist. So I kind of understand the medical model. And I worked in a managed care company before I went into private practice. So I know that people are squeezed for time. Providers are squeezed for time.
Right.
But the questions about HRT can be very complicated. So first, let me start with, can you give an understandable, simple, as if I was 5 years old, explanation about what is the difference between the HRT that the doctor offers you and what they call bioidentical?
Sure.
Because every time I even read it, I don't understand.
Yeah. So the term bioidentical is simply an adjective. And actually, some of the treatments that your regular traditional in-person doctor could offer you are actually bioidentical. What that word means is that the structure of the medication that they're ordering is structurally identical to the hormone that your body would create on its own naturally. So in women, that basically means it's one of the forms of estrogens that our body would create normally, which we have 3 types of estrogens circulating in our body as human females. We have estradiol, estriol, and estrone. And so most bioidentical HRT that's out there will have estradiol or a combination of estradiol and estriol. The estrone part of our estrogen tends to be stored in fat cells. That's not something we typically make in a medication form. But the other 2, like you could actually get, a bioidentical form of hormone replacement therapy from your doctor. And then the other thing too to consider is the progesterone side of things too. So bioidentical progesterone is actually the word progesterone. You'll see the word progestin listed a lot, like in birth control pills or other forms of synthetic hormones. Progestins are a synthetic version of our body's natural own progesterone. So as women, we have estrogen circulating normally, progesterone, and also testosterone. I don't think a lot of women realize that we also actually have testosterone in our bodies as well.
Right. And all 3, when you go through perimenopause, they all fluctuate in different
Yes.
But also related to each other, right? Because
Yes.
hormones, how much of one hormone affects how much in response of what the other hormones are produced by your ovaries, correct?
Right. Like our female hormones are released in a pulsatile fashion, which is why, they vary so much during the normal month, like when we're actually actively having menstrual cycles. If you look at a chart of the menstrual cycle, there's these peaks and valleys of hormones throughout the month. And that's why often we'll notice different symptoms. That's why, when you're actively menstruating and having periods, you'll have the changes throughout the month of having PMS, and then also, having changes in your mood in response to what the hormones are doing as well. So as we're going through the change in midlife, and as our body is starting to decrease the regular production of these hormones naturally, we can see a lot of changes to the way they're released throughout the month. And sometimes from month to month, things may be different too, because the production overall is decreasing and in time as we age.
So how do you even know where to start? I'm older than this, but like, let's say I'm a 45-year-old woman who's still getting their period, and it's a little irregular, but it's not super crazy yet. It's like 1 month it's day 32, the next month it's day 27, and then it's day 36, and then it's because that's what happened to me.
Yeah.
And that I understand that that's normal for it to start wobbling, like when you start.
Right. And that's one of the earliest symptoms a lot of women will notice is the menstrual irregularities. Like someone who maybe was regular, like clockwork, and had 28-day cycles, to the time of day, all of a sudden might notice more, erratic timing of their cycle, or even changes in the actual menstrual bleeding. And some of them will actually start to skip a month or get breakthrough bleeding and have 2 episodes of bleeding in a month. A little haywire. Yes.
Flooding happened to me in my early 40s. It was like,
it's scary.
And yeah, it was not fun. But so how do you know? Because I'm on just regular estradiol, like the pill, which was what was offered to me by my gynecologist. And that's it. She also had me on, but it was expensive and I ran out of them, a vaginal tablet that was like 10 milligrams. But how do you know? Because there's like patches, there's pellets, there's creams. How do you even make an informed decision about what you need? Like, where do you just hope that your doctor knows? Because a lot of doctors have no training in menopause.
That's so very true. I mean, it's definitely a lack in education in our medical profession, but I think more and more, for physicians like myself, as I started to go through the change personally, I started focusing all my education efforts into learning more because I felt very ill-equipped to even get care for myself. And that's kind of how I improved my own knowledge to start taking care of more menopausal patients. But I mean, honestly, the first place to start is symptom recognition. And the hardest thing for women to know is when they're actually in the perimenopause transition, because the symptoms can be very subtle and very vague at first. The irregular periods could be the first thing, but then also a lot of women will start to notice brain fog, problems with attention, maintaining, focus as far as their cognition, sometimes mood changes. Like we'll start to see a lot of those symptoms before we see the hallmark hot flashes and night sweats and vaginal dryness.
In retrospect, I'm like, oh, that severe spike of anxiety in my early 40s, my anxiety went off the chain. I'm like, that was the first time.
Yes. And similar for me too, with my own personal experience. I'm 46. I started going through perimenopause at 41, 42, but I didn't recognize it at the time. It's retrospectively, I've gone back. I just thought, well, I was going through a divorce. I was changing jobs. I just thought it was stress. Like I kept rationalizing that it was so many other things rather than actually understanding what was fundamentally happening in my body. So, but when it comes to choosing a treatment method, for a lot of women, I tell patients it's kind of like trying on clothes, right? So we each have our own preference. Everyone likes a different cut of jeans. That's why you have like skinny jeans, bootleg, like the straight leg, the boyfriend cut, this and that. So much of trying to find the right formula for some patients is about trial and error. And so we usually talk about different absorption rates. Like I'm a big fan of transdermal methods, meaning like the topical, like a patch or a cream or a gel because of you can bypass the GI tract. So if a woman tells me she got terribly nauseated taking birth control pills in the past, which are different medication, different hormones, but if they got a lot of GI side effects with taking hormones in the past, then I usually try to recommend against taking something orally because we can bypass that GI side effect profile, meaning that when you take a pill, it has to get broken down by your stomach, processed by your liver before the intended hormones get to the tissues via the blood, like they're intended to. So if someone struggles with nausea, if we don't give a pill form and we put it through the skin, it gets right into the bloodstream and circulates to the tissues it needs to. So you can bypass the nausea and the stomach upset a little bit for those patients. So it really is about patient preference and just kind of coming up with a conversation as to what they think is most attractive for them to try. And even though I might think the transdermal methods are better, you know yourself as a patient better, right? So if you're already taking other pills or you take other vitamins in the morning, and it would be much easier for you to incorporate just adding one more pill to your regimen, you're going to be more likely to be consistent with the medication if it fits into your lifestyle the best, right? So, even though I might think that another method is better, every woman is unique and what fits into her lifestyle is unique to her. So it's really like a shared decision-making process about trying to find what method of hormone replacement therapy is best for each patient. And when it comes to pellets, I'm not a huge fan of pellets just because it's an invasive procedure. Typically when they make a pellet, it's a 3-month reservoir of medication. So they're trying to come up with the best dose for you. But then if it doesn't work for you, you're kind of stuck for that 3 months until that pellet totally absorbs. Right. So if you have side effects or problems, then you're kind of stuck with feeling that way until they, readjust your formulation. So I'm kind of against, invasive procedures, but I've had some patients over the years that get pellets and love them and do wonderfully, but it's not for everybody. So.
Thank you. That was really, really clear.
Sure.
So is HRT like something that has to be reevaluated every couple of years? Like, does your body continue? What I'm trying to ask you in a clunky way is, does continue to change after menopause? Because I think there's also this belief that once you go through menopause, you're like this static, flat line for the rest of your life, and there's going to be no further adjustments needed because you're taking your hormones in. Your body isn't cycling anymore. Right. So is that not true? Do you continue to go down in your natural reserves?
Yeah, you can continue to have some fluctuations because of body composition, right? So we do store some of our estrogen in our fat tissue. So if someone has a significant weight fluctuation, if they gain a lot of weight or if they lose a lot of weight, that can change their requirements for hormones. But also, I think there's a huge piece of this too that we haven't talked about yet, but it's the whole body, whole mind, the nutrition aspect of things and the wellness and fitness aspect of things. So the way that our metabolism works, if you went from being a very sedentary person and all of a sudden you start adding in movement and adding in weight training, that may also change your requirement for hormones because your metabolism and how you break down those hormones may change. And also, even though our ovaries, once we're postmenopausal, our ovaries aren't really producing their own estrogens anymore, we still have enzymes that are circulating and converting hormones in our body. So there's still things that are changing and can be some fluctuations, and also our female hormones respond very widely to changes in our stress level, our anxiety level, our sleep hygiene. If we don't sleep well, sometimes the next day we might notice more hot flashes, more night sweats, less resilience dealing with a lot of the other things happening in our body. So it still is possible for things to change. And so I often tell patients, when you notice symptoms starting to creep back, that's when we need to try to reevaluate. And if it's a response to something acute, like maybe you were recently ill and you had COVID or you had the flu, I like to kind of get back to baseline and your normal baseline state after healing before we go making wild adjustments to hormones, because sometimes as our immune system is fighting off illness, that can change our needs for hormone replacement too. So there can be acute changes like that can change our symptom, profile. But I don't think it's unreasonable to think to reevaluate, especially if the changes are persistent.
And how long can you safely stay on HRT? I was reading on the Winona website that if you start HRT before you're 60, you can stay on it forever?
Indefinitely, really. I mean, years ago, when I was a resident learning how to be an OBGYN doctor, they used to teach us, the smallest dose for the shortest duration possible.
Right.
But it's a very closed-minded view of what it takes a woman to be well. And, when we're looking at now, like more about longevity and quality of life and maintaining vitality, I think as long as you reevaluate looking at a patient's total wellness, right? If the benefit of the HRT outweighs the risk as we continue to reevaluate over the years, then there's no reason why a woman can't stay on it indefinitely. And if you ask female OBGYNs that are actually on HRT going through their own perimenopause and menopause, every one of us will answer, you'll have to pry it out of our cold, dead hands. We love the difference it makes and the health benefits it gives. Why stop it?
Yeah, I remember when I had been on it for a month. This is now, I was probably like 48 or 49 when I was started on it. I wasn't done getting my period yet.
Mm-hmm.
My doctor started it. My doctor in New York before I moved started me on estradiol and progesterone, and I was still getting my period sporadically. And I felt like a plant had not been watered in months. Like a month in, like all my joints stopped hurting.
Yes.
Oh, I dropped a little weight. I felt more energized. I was sleeping better. I wasn't waking up like covered in sweat like 3 times a week, 4 times a week. It was like a miracle.
Right. Yeah, it's amazing. I think that we watch all these symptoms creep in and all these things that are starting to happen to us. And a lot of us think like, oh, it's us aging. But when you feel the difference, when your body is optimally functioning with that estrogen that it's lost, it really is life changing for a lot of women.
Yeah. And it doesn't have to be so hard to age. I mean, enough things about aging are hard.
Right.
Right. All this responsibility, you're caring for sick, dying parents or parents that are just high need in some way just because they're the reality of their aging.
Yes.
Right? You have adult management of your own life, career, job stress, everything. You don't need to feel like crap on top of it. And there's no reason.
Exactly.
To suffer.
Exactly. I totally agree. And I think that for far too long, women have been suffering with this and not been given answers. But we do a really good job of taking care of other people in our lives as women. We're not so great about taking care of ourselves. But now that tide is changing and now women are deserving and demanding better.
Yeah.
We're not aging like our grandmothers did. And no longer are we going to, take it, laying down that we're going to age and all of a sudden be an AARP, be like the Golden Girls, and age so rapidly in our 50s. I mean, so many of us want our youth and vitality to continue and to be our best self. And we have to do that for ourselves, to be the best version of ourselves.
Absolutely. I think Gen X has really changed, not just changing, it has already changed the conversation.
Yeah.
I think Gen X changed the conversation so that millennial women who are now getting ready to go into perimenopause don't have to have the fear. They have the education that they need, I think, because now it's talked about more openly. Whereas we were sort of, I mean, I remember I felt so alone because my friends weren't really talking about it yet 10 years ago.
Yeah.
And I felt so ashamed that it was maybe shame. Well, no, shame is the right word. I felt so much like anxiety and shame, like, oh my God, like, how did this happen so fast? Like, I feel so like, am I really here already? Like, how could I already be here? Right. This is horrible. Like,
exactly.
Right.
I mean, even as a board certified OBGYN, I was totally ill prepared for my own transition. I really thought, based on my education and me studying women's health my entire career, that I would be fine until I turned 50. And then I expected that symptoms would start about then. Right. But you don't realize that, 52 is the average age of menopause in the United States, but symptoms can start up to 10 years before that. And if you're a late bloomer with menopause, that means, it might start in the mid 40s. But if you're early, like if you're going to hit menopause at 45 or 46, that means symptoms can start as early as 35 for some women.
Yeah.
And so it's it's a huge part of our own education into our own physiology and our own bodies that we need to share with the younger generations. We talk to our girls and our daughters and younger women about their periods and what to expect. And there's so much focus, and you see stars and you see people in politics and in the media starting to talk about this more and to be open about their own experiences, which I think helps the dialogue overall.
So. Yeah, I think so too. I think we're finally like getting the message out there that your life is not over. Like menopause is not the end of your life. It's not the end of your sex life. It's not the end of your creative life. It's not the end of your social life. It's not the end of your ability to do things in the world. I think we're finally changing that conversation, and thank God.
Yes, thank God is right.
Because nobody wants to be like, okay, 47, it's time for me to put my, my shapeless schmata on and a Marlboro light on my porch as I curse the neighborhood children. It's not what I was picturing for myself. I'm not ready for that, and none of my friends are ready for that.
No.
It's just, yeah, thank goodness that's changing. So talk to me about progesterone, because nobody understands what that does. So why don't you explain to my audience who probably are just so thirsty for this knowledge?
Yeah, absolutely.
Estrogen keeps your ovary. All right, why? Maybe we don't know it all. Can you just kind of give us a little like what's estrogen, what's progesterone, and what does testosterone do for women? And is there anything else we should know about?
Sure. So estrogen really benefits every tissue in our body, really by optimizing its function. So in the joints, it helps to keep joints more lubricated. In our heart, it keeps the muscle healthier, keeps our blood vessels more supple and elastic. So it actually is cardioprotective against like heart disease and things like that. But also in our brain, estrogen is essential and integral for the production and the transmission of neurotransmitters. There's a great book out there called The Menopausal Brain. It's written by a PhD neuroscientist who's big and educating on women's health, specifically with neuroscience. Her name's Dr. Mosconi. Great read. It's actually on my bedside table now. So there's so many aspects of estrogen that are positive. But one of the very negative things that estrogen could do when you take it by itself, it could actually cause the uterine lining to overgrow. So the way that our female hormones are balanced, progesterone kind of helps to balance out the estrogen. So like when we're actively having cycles, when we're in our reproductive prime, that estrogen helps to fluff up that uterine lining to prepare for a pregnancy. And then when we don't get pregnant, when an egg doesn't get fertilized after ovulation, progesterone then increases in our body to cause that uterine lining to shed. So when it comes to menopause and giving hormone therapy, when we're giving estrogen, if you still have your uterus, it is absolutely integral to have progesterone with that so that we keep that balance inside the uterine lining so that you don't end up with a precancerous overgrowth inside the uterus. So for a patient who's had a hysterectomy, we don't necessarily need that extra progesterone. So there are some cases where some women might benefit from adding in progesterone even if they don't have a uterus, but those are kind of unique situations like endometriosis or other situations where they might benefit from the progesterone as well. But studies actually show that, of all the women out there with hormone therapy, a lot of the biggest risks that women worry about, and probably the biggest question I get from patients is, well, if I start taking hormones, am I going to get breast cancer? There's this like generalized societal fear that has been put out that, taking any kind of HRT is going to cause you to have breast cancer.
Right.
But the truth is that more women die in the United States of heart disease and heart attack than ever die of breast cancer. But the increasing studies are coming out saying that actually taking estrogen alone, HRT, actually can reduce your risk overall. It's the combination of estrogen and progesterone that can slightly increase your risk of breast cancer. But whenever we talk about any medication, there's no medication without risk. Even taking Tylenol, which we think of as an over-the-counter, like very safe medication, can be dangerous if you take it too much or in excess. So, this is one of those conversations we have with patients talking about the risks and benefits. But for most women that still have a uterus, we do need to give back a dose of progesterone when they're taking estrogen to protect that lining of the uterus from overgrowth. Now, testosterone, our ovaries also create on its own as well. And that's kind of the driver for our libido, our sex drive, also our muscle strength, our vitality that way too. And also testosterone helps to drive our metabolism as well. However, in the United States, testosterone is only FDA approved to give to men because most of our medical availability of medications is very paternalistic driven, right? So unfortunately, most women that are taking testosterone supplementation are doing so off-label for an FDA-approved medication for men. And as a result, a lot of men actually abuse testosterone, like it's been abused by the bodybuilding community and by athletes. So it's considered a controlled substance in the United States. So there's another way to get testosterone if you don't want to take it directly, and that's by using a hormone precursor supplement, which we actually use at Winona. It's called DHEA. It's dehydroepiandrosterone. It's basically one of our body's own precursor hormones that when metabolized by the body gets broken down in our own bodies to estrogen and testosterone. So it's a gentle way to raise testosterone levels without getting a little overboard on the dose of testosterone. And so it's because if you take too much testosterone as a woman, it can cause masculinizing side effects. So you could get a beard growth, a mustache. You could have changing and deepening of the voice. The clitoris could overgrow and become larger. And you can also get male pattern baldness too. So there's a very discrete window, like a therapeutic window for when testosterone levels are safe for women. So DHEA is a lot lower dose. And so it's a safer way to boost that testosterone naturally without running the risk of those other side effects. So that's something that we usually recommend as well.
Thank you. So for a woman who, say, had a hysterectomy and had her ovaries out, is progesterone something that could still be used to manage like sleep and anxiety? Because that's what progesterone helps with, correct?
It can. It's not necessary for all women though. So because taking the combination of estrogen and progesterone can slightly increase the breast cancer risk, it's a conversation we'd have with patients individually. Right. Because if they can get the benefits of sleep and improved anxiety from their estrogen alone, they might not need the additional progesterone. But it's still a possibility to use even after you've had a hysterectomy. And that's, I think, every patient's unique and what formula works best for them. Often I'll have patients that have had a hysterectomy try with the estrogen alone. And then if they're not getting the benefits of sleep improvement and their mood hasn't improved, then we can always add in the progesterone. But I'm very much like make it easy, use easier regimens, not changing dosages based on the time of the month or using cycling different doses, because that just makes things a lot more complicated. And less is more. I think most of us want to take less medications overall as we get older.
Right.
But yeah, it is a possibility to add in if we need it for some patients, for sure.
What are the most common things that women come with their biggest concerns about menopause? Is it vaginal dryness, weight gain, hot flashes? Like, what's the most troublesome?
I would say the weight gain, particularly in the midsection, hot flashes, night sweats, brain fog, and mood disorders. So most patients that come to me, the biggest complaint they have is that they've been suffering with these symptoms for years. And they keep going to their family doctor and to their OBGYN and being told, no, this is a normal part of aging. Here's an antidepressant, or they're offered a birth control pill to treat their symptoms instead of HRT. And so they're frustrated because often they've been started on something that maybe addressed one symptom, but doesn't address everything else. And so they come to us in frustration, just still feeling awful.
Okay, so what's the difference between a combination birth control pill and HRT? What's
the biggest difference is that birth control hormones are synthetic hormones, and the whole purpose of the medication is different. So when we give birth control, basically what that is doing is it's suppressing your body's own creation, like that normal pathway of hormone creation, so that you do not release an egg, so that you do not ovulate. So it's suppressing your ovaries' normal hormone production, which when you're also having decline of hormone production, now you're giving a medication that's suppressing it worse. It actually, it doesn't really help all the way. And also those hormones are synthetic, so we have to go a little higher dose compared to what your body probably would be able to accept with hormone replacement therapy. So overall, they have different purposes and a different function in the body. So if someone's really suffering from menopausal symptoms, it's not the best treatment option. But often that's the first thing an OBGYN who doesn't have a lot of menopause training will offer their patient, because they've been using this particular medication for years. They've prescribed it to hundreds and hundreds of patients, so they feel comfortable with it. Right. Even though it's really not the best thing out there to really address their needs. So, but a lot of people are at fault of offering that first. And it's unfortunately not the best way to treat these symptoms.
Yeah. that's really helpful because literally the first doctor I went to years and years and years ago was like, oh, it's the same thing. It's the same thing as birth control. That was a doctor who said that. And it's not, I guess it is not the same thing.
No, I mean, when you look at most birth controls, it's a combination of a form of estrogen, most of the time ethinyl estradiol, which is an isomer of our normal hormone, but it's not the same, and a progestin, which is a synthetic progesterone. And so even if you go very low dose with a birth control pill, it's not the same as what your body would be producing, and it's still higher dose than what you could get with hormone replacement therapy.
Yeah, like saying that Advil and Tylenol are the same or...
Right. And birth control pills are great, and they're actually better than HRT when it comes to preventing. Like HRT will not prevent pregnancy because if you're still ovulating, it's not going to prevent ovulation. We're just adding back low doses of hormone that your body is no longer creating. It's not suppressing any natural function whatsoever. But if you have horrible heavy periods and need a treatment for that, HRT might not be as helpful as that, than birth control for that. So birth control pills are great at preventing pregnancy and regulating periods because they suppress your body's own natural function, but they're not great at addressing the menopause symptoms.
Wow. So I didn't know that. I would have assumed that if you were on HRT and you were like still getting your period once in a while, that the HRT you wouldn't need birth control, but that's actually really good information to have that you need birth control.
Yeah. So for any woman who's perimenopausal, but still actively having cycles and could be ovulating, I always ask them, like, are you on some form of contraception? And a lot of times if they are not, I tell them that it's really important that if they were to get pregnant, that they stop, HRT right away, because obviously if you have an unwanted pregnancy, then it can cause problems to be taking extra hormones that a fetus could get exposed to. But for women that are on birth control pills, but also having symptoms develop, it's safe to take both until you're out of that risk of unwanted pregnancy, which for most women, that risk dramatically drops down at age 50. Our fertility declines after 40, but it's still possible to have a perimenopause baby. So if you don't have a permanent sterilization method, like a partner with a vasectomy, or you don't have your tubes removed, or an IUD or something similar, that it's important to protect against pregnancy. A lot of people wouldn't want that whoops in their late 40s.
You're already tired enough.
Exactly.
Do you think eventually there'll be some kind of like IUD-like device for menopause where the hormones will be in there? And there
are vaginal rings, kind of similar to the NuvaRing, which is a birth control. There are rings that do deliver. But the actual absorption from the inside of the uterus of hormones, like the progesterone IUDs that are out there for birth control, they work very locally on that uterine tissue. So there's not a lot of systemic absorption from the vessels of the inside of the uterus. So I don't think it would work the same way that we would want like for systemic HRT. But there are systemic versions of HRT available that are in the form of like a vaginal ring. So it's just that the mucosa, like the tissue in those areas in the vagina compared to in the uterus, it's a little bit different as far as how well it absorbs the medication.
So talk to me about Winona and the services that Winona offers women who are seeking answers and support and help. Does Winona talk broadly also not just about hormone replacement, but the things you mentioned earlier, lifestyle support, nutrition support, helping people, because we're not just uteruses and ovaries.
Right.
There's all these other things that contribute to functioning, sleep, eating, exercise, mindset, mindfulness, all those things. So does Winona help with all of those things?
Yeah. So we primarily our services, I mean, we're an asynchronous telemedicine company. And so primarily as far as prescriptions and ordering medications, we primarily do HRT. But our website is free to access. And we also have a platform for really educating patients and trying to get the information out there. We do live workouts for patients. We do have some partnerships, trying to do nutrition education and fitness education, so that we have that available, because I think that women need to know that this is a whole wellness project. When you go through menopause or perimenopause, it should force you to kind of pause on your own lifestyle and see what you need to do to optimize your own wellness and health moving forward. It's not an easy fix. Like taking a pill or starting a medication is not the only thing that's going to make this transition easier. But yeah, we definitely want to make sure that there's information and education out there and available for everyone. And it's part of my counseling too. I think that, when women come with the expectation that, maybe starting HRT would help them lose weight, I also talk to them about nutrition. How much protein are they getting in their diet? Because to me, that's so very important that we look at all those things and that we're, a patient's well-rounded to really get their health better. Obviously, compared to just medication alone. Yeah.
It's like when you go through perimenopause and menopause, your whole body changes.
Mm-hmm.
I think actually your brain changes in a lot of ways, because I feel like this might sound dramatic, but I feel like I'm a completely different person.
Yeah.
Like on the other side of it, I feel like my attitude is different. What I worry about is different. What I care about is different. My sleep is different. My eating habits are different. My exercise preferences are different. I wasn't expecting that.
Right. No, and it's true. And I think that's only natural that as our bodies are changing, they're evolving, right? And so our attitudes and our feelings toward things have to evolve with it too, And
I think it's time to normalize that it's okay and it's safe to be different than you were. And you should be different than you were.
Absolutely.
When you're 30 years old. You should be as, wrapped up in the things that you were concerned about in your 30s at 55. You should be focusing on other things because you're in a different phase of your life.
Exactly. Yeah. And I think that for a lot of women too, is that, you can spin this to be a very empowering time too. I think that, like I mentioned earlier, so many women spend their entire lives caring for other people, worrying about so many other things. But really, when you get to this part of your life, like you really need to put the attention inward to figure out what is most important to you. How can you be your best self? How can you move your body better? And so I think there's a wisdom in that for a lot of women, and, we're less willing to take, other people's bullshit.
Absolutely.
In their 40s and 50s. I mean, to me, it's been very empowering that, after going through this, I really have no time for toxicity, for anything that's not going to serve me or my family well. And it's much easier for me in my 40s to say no to things and to really put value on things that are important to me and not worry so much about anybody else and what other people's expectations are. And I think that's important for all of us to do.
Yeah. It is one of the biggest gifts of aging is that detachment from the concerns of what is everyone going to think of me.
Right. Exactly.
Yeah. Is Winona accessible to women all over the United States?
It is. So we started out in California, expanded to Texas, and I joined the company in 2021 when they were expanding to Pennsylvania. I'm located just outside the Philadelphia area. I believe now we're in 34 states and that's growing. So we go state by state with our expansion because each state has their own different laws about telemedicine and what's required. There's still some states that require face-to-face, like live visits. But unfortunately, for a lot of women, that can be kind of an impediment and a roadblock because just like trying to get into your in-person physician to go to your family doctor or your OBGYN for an exam, sometimes you're waiting weeks, if not months, to try to get in. Yeah. The nice thing about the asynchronous nature of our site is that you go on, you have an online adaptive questionnaire, which asks you all the pertinent medical history that we need to know if you're a safe candidate for HRT or not. And then if you are, your chart is forwarded directly to a doctor in your state for review to start the conversation. And we can message back and forth to clarify things, to go over treatment options. But then if you're a good candidate and we agree with the treatment plan for you, we can order medications for you. They get filled by our pharmacy and mailed directly to your house. So theoretically, if someone were to sign up today and their chart's reviewed within 24 hours by a physician, they could be getting meds within a week mailed to their home.
Wow.
Which is really nice. And the benefit of the asynchronous nature of our site is that if a woman wants to get in touch with her doctor, she can feel free to message her doctor 24/7. There is no going online waiting for a visit like a week from now. And if a woman wakes up at 2:00 in the morning and the night sweats are unbearable and she wants to change her dose, she can get right online on her phone and message her doctor saying, hey, I've been on this dose for a while. I think I need to increase it. Whereas if you're waiting to get into a nutritional doctor, like you might have to wait for another appointment, or there's a lot of waiting involved, which the asynchronous nature of our site really makes access to your provider more instant. And all of our doctors are board certified physicians. There's a lot of sites where you might have a nurse visit or a nurse practitioner, but these are all board certified physicians. And the nice thing is just having the access. And it doesn't cost any money to message your doctor. The only thing you pay for with us is the medications, which I think is a lot more flexibility. And now it's not for everybody. If somebody prefers to see their provider face to face and they really want that live video visit and like a virtual visit like that, there's other sites that do that. I mean, there's plenty of competition out there, which we think competition is good because honestly, it's making care accessible to more and more women, right? So yeah. So, and I've even had patients that have come to us because their doctors have said no, and then they do so well in our program. They go back to their annual visit and their doctor sees how good they do, how much healthier they look. And we're starting to like indirectly convert some of their doctors because I've had patients come back to me and say, I shared with my doctor what my dose is. They're so happy with how I'm doing. They're going to take over prescribing for me. So we lose them as a patient, but I'm so happy for them that they found somebody willing to, prescribe for them and that they have access to care where they live, but because we're really a bridge for those women who don't have a way to get treatment otherwise.
Right.
So if you're getting too many closed doors and too many, no answers and you want to start treatment, online telemedicine is a nice adjunct to your in-person care. I mean, we can't replace it, right? You still need to have an in-person physical every year. You still need to have a breast exam and a mammogram. And if you still have a uterus and cervix, you still need to have a pap smear. We obviously can't do that through telemedicine. So we can't replace your gynecologist, but we can augment the care that you get in person for sure.
That's absolutely amazing. So it's not a Zoom meeting. It's messaging back and forth.
Right.
They assign you to a provider. So you fill out an application, they review it, they assign you to a doctor, and then you have like a chat, a virtual, like a online chat back and forth with the doctor.
Yes.
That may be in real time or maybe over the course of days or weeks.
Yeah. Typically our response time, we tell patients that they should be hearing back from their physicians within 24 hours of any message they send. So yeah.
And then you could message the doctor like a month later, like, hey, I'm still having like horrible night sweats. Do you think I should still be taking this dose?
Right. Okay. Exactly. Like we want them to message us anytime they have a change, any questions they have, any concerns, or if they want to talk about changing dosages. Or I've even had some patients that start on a cream, but then they say, you know what, I'm worried, I'm cuddling with my dog at night and I'm worried the dog's getting some of the cream. Can I switch to the patch? And so we switch things up. And so it's nice to have that real time exchange with patients and, be able to change things and adjust things if we need to.
I know that you don't have that much more time to talk to me, but I do want to hop on that for just 1 second.
Yeah.
So if you are a straight person having sex with a straight man, is it safe to use, would the vaginal cream hurt your partner?
No. So typically when it comes to application of creams, on the regular part of your body, like on the arms or even a vaginal estrogen cream, the active medication that's suspended in those creams is typically absorbed within 30 minutes of application.
Okay.
So, typically there's not a risk of it transferring to anybody else. I've had patients that have younger kids, be concerned about like kids getting exposed and, or partners getting exposed. But yeah, as long as you're rubbing it in, like our body cream, typically most women apply it on their forearms. And as long as they rub it in until it dries, it's typically absorbed within 30 minutes and they don't have to worry about the cream exchange to someone else.
Oh, that's good to know. Thank you for answering that. Last question before I know you have to hop to your next meeting. How do people pay for Winona? Does it accept insurance? Does it not accept insurance? Is it self-pay? Is it HSA?
Wow.
Like, how do people pay?
We are self-pay. Right now, we don't accept insurance just because we find that there's too many roadblocks to getting insurance to pay for medication. So, but we do accept HSA and FSA cards. So if patients have those as part of their insurance plan, they're welcome to use those to pay for the medication. I have also had patients pay out front for their medications and then submit receipts to their insurance company on their own and get reimbursed. And so that's something that's a possibility as well. So yeah, so that can be, a rate limiting step for some patients. There are a couple other sites out there that do insurance. So if that's a huge factor for you, like the financial piece of it, then there are other options out there too. But yeah.
Okay. Well, I'm going to put a link in the show notes for any listener who is intrigued and wants to explore HRT and get all kinds of answers and get all kinds of assistance thank you for giving a clear outline of a very muddy, difficult, complicated, overly complicated subject that a lot of women have a hard time navigating. It should be
Yeah.
hard.
It shouldn't be this hard. I totally agree. And it's one of those things that I think the more we have these conversations, more women learn about it, then they're going to be talking to their friends. Sharing information with other women is so very important so that nobody is going through this time in the dark. I think it's so important.
Yeah.
And our team at Winona would be remiss if I didn't share my social contact with you too. So I like to do a lot of educational videos, and we have a Winona page on Instagram, Facebook, TikTok, all of the above. But I also have a personal one. It's Dr. Cat OBGYN on Instagram. And I think there's a Facebook page and a TikTok too. But if women want to just follow to get more information, more educational content, because I think that's probably one of the most important things I've done in my career is education. I think knowledge is power, and we as patients need to take ownership of our own health and really learn as much as we can about our bodies so that we are best equipped to take care of ourselves, moving forward in our lives. I think it's so very important.
Absolutely. I was hoping that on my 48th birthday, I would receive an update of Are You There, God? It's Me, Margaret, for, this activity. It never came in the mail. So
I know, right?
Write it.
Yes. That was such a wonderful book.
We need one for this stage. We really do. Because I feel like so many of my friends are educated people and in the dark. My listeners are educated people and struggling. And really, you don't have to. It's completely unnecessary.
Completely unnecessary. I agree. Let's help each other.
Yeah. Thank you so much for coming on Your Magical Midlife.
Oh, thank you so much for having me. I loved having this conversation with you.
Thank you so much for listening to Your Magical Midlife. I'm Kate Higgins, your host. You can follow me on Instagram at Your Magical Midlife. And you can check out my offerings on my website, yourmagicalmidlife.com. I offer individual and small group coaching, as well as luxury retreats for women in midlife and beyond who are seekers, dreamers, and unconventional thinkers. You can book a complimentary discovery call in the calendar link in my show notes. If you've enjoyed this episode, I'd appreciate it if you left a 5-star review on Apple Podcasts or share this episode with a friend. And I will talk to you next week.